Hello, my name is Dr. Amy Krambeck. I am professor of urology at Northwestern Medicine in Chicago, Illinois, and I am the chief of the division of endourology at Northwestern. I specialize in HOLEP, or holmium laser enucleation of the prostate, for BPH, as well as complex stone surgical interventions. The name of this case that I'm going to present today is the hesitant patient. So this is a 73-year-old gentleman who has been struggling with lower urinary tract symptoms for many years. His symptoms consist of nocturnia 4 to 5 times per night, getting up every hour almost, daytime frequency every half hour to an hour, and a high postcode residual of 400 cc's. His IPSS score was 25, and his Michigan Incontinence score was 8. The patient has tried multiple medications for the last 10 years, including double dose of tamsulosin as well as finasteride, with no resolution of his symptoms. The patient's biggest fear is that he would be diagnosed with prostate cancer and be unable to undergo a radical prostatectomy should he have any type of surgical intervention for his BPH symptoms. So he had avoided any type of surgery. Eventually, in 2019, his symptoms became so significant that he required a catheter placement, and he eventually underwent a transurethral resection of the prostate, where 10 grams of tissue was removed. He presented to me with severity of his symptoms nearing that of what he had in 2019. His PSA was elevated at 10, so he underwent an MRI of the prostate, which demonstrated an exceptionally enlarged prostate, approximately 250 grams in size. There's significant intravesical protrusion of the prostate, and you can see a minimal TURP defect. After a long discussion with this patient, he decided to go forward with HOLEP. He underwent an hour-and-a-half surgical procedure where he had 200 grams of tissue removed. His catheter was left in for 4 hours after surgery and removed that day. He was able to successfully void and go home the same day. Pathology did not show any evidence of prostate cancer. So I would think the take home from this case is that if patients' symptoms are significant enough, they are candidates for surgical intervention, and it does not burn any bridges for potential prostate cancer treatment down the road. This patient was very concerned and had misleading information given to him that he would not be able to be treated for prostate cancer should he undergo a full definitive treatment for his BPH. He underwent the appropriate workup with a PSA, and when the PSA was elevated, he underwent an MRI to look for any suspicious lesions. Since his workup for prostate cancer was negative, he felt more comfortable moving forward with the HOLEP surgery. Should we have found prostate cancer in his HOLEP specimen, then treatment options really vary based on the pathology. About 13% of the time, despite an adequate workup, we will find prostate cancer in the specimen. Most of the time, this is grade group 1, Gleason 6, and low volume, less than 1% of the specimen. And these men, active surveillance is totally appropriate, and we have seen no deleterious effects when instituting an active surveillance protocol. If for some reason we were to identify a high-grade cancer in the specimen, the patient can still undergo any type of treatment intervention needed. Should he require a radical prostatectomy, it can be done after the HOLEP surgery. Not to say that it's an easy task, but it's definitely possible, and with the right surgical counseling and approach, they can have an excellent result. Patients are also candidates for radiation therapy, hormone therapy, cryotherapy, and everything in between. So the take home is, if you're having significant symptoms, do not do half measures to relieve your symptoms. This patient underwent a TURP that was minimal in an attempt to try and preserve the anatomy of the prostate, and in the end, he just had worsening of his symptoms and a delayed treatment of his significant, massively enlarged prostate.